So, everybody tired of talking about opioids yet? I know we had an entire panel yesterday. But you get to hear it one more time, so congratulations. So, I was able to actually get connected by Larry over here with Dr. Clar as well as Dr. Nelly, both great people at Duke University. I'm really thankful that they were able to allow me to do this work with them. So we are talking, first of all, my disclosure statement. I have nothing to disclose. We follow Duke IRB. That is it. So overview, pretty standard look at a project, introduction, methods, results, discussion. You've heard it over and over and over. Here we go. So you know the story. The latest and greatest, I will point out, Purdue Pharma. There's now, the last count that I had was 27 states are suing them, and there's at least 40 states that have a suit of some kind against a pharmaceutical company in this country right now. That is where we are at with the opioid crisis. But what is North Carolina doing about it? North Carolina passed the STOP Act. It was passed July 2017, enacted January 2018. Most of you know it as the reason that you have to sign every 5 days, especially inpatient people, have to sign a new opioid-related prescription if your patient needs pain every 5 days. It's annoying, but we need to keep track. The other things that happens with this law, however, is that they're bringing tighter controls on opioid prescribing. There's electronic prescribing now, so we can actually tally numbers. We can see statistically who's getting what, and also nobody's falling through the cracks. It's great. And also, we're able to give out Narcan or naloxone for people to recover from. But when it comes to physician leadership, we got to figure out, okay, what as physicians specifically do we need to focus on that is continuing this crisis right now? Okay, so first, it's opioid overprescribing. I'm sure everybody has heard this. I'm sure everybody's read this. This is some of the data that you will see. Major medical center with 3 academic institutions. They all see the wide variation of acute care with post-operative pain. Now, surgeons in the room, do not feel bad because we are failing you too. You don't have guidelines. The guidelines on acute pain right now is it is up to the physician's discretion. That is it. So a surgeon can take a look at a patient and go, yeah, they look like 10 days. We'll throw it at them. Not backed by EBM. The other thing too, unused dose outcomes. So a study actually similar to this, they did this in Colorado. They had some decent reports of people not using opioids. Okay, very good. However, the amazing thing is a lot of people, 77%, 73%, they're keeping it in an unsecured location. The amount of days that you have an opioid prescription out in the air like that increases the risk exponentially of having that medication go to something that is not indicated for. That is crucial. That is almost sad. Clicker. There we go. So, going off of that, why this study? So, all the females in the room, you can see I'm a male, but I'm not speaking for you, but I'm sure you can also agree with AJOG. It is a painful procedure for those who have gotten C-sections. For the C-section data, Dartmouth was one of the first medical centers to really tailor, you know what, why don't we kind of decrease opioid prescribing, working with enhanced recovery after surgery paths. Let's do something that is either decreasing the opioids or getting rid of them altogether. Let's try and do something like that. Major quote from that study, and I will read off of this just to emphasize it. Opioid-free multimodal analgesic techniques promoted in ERAS paths will be rendered moot, unable to significantly impact opioid epidemic if physician behavior is not modified. That is huge. If physicians do not modify their behavior, and I'm also talking to the advanced practice practitioners out there as well. If we do not modify our prescribing behavior, this will continue. So is my primary goal really abolishing all opioids? That is a no. What I do want to look at is, can we use a combination to better help patients? And so with this, I'm looking at prescribing habits after C-sections to see, can we come up with something that maybe go into a guideline later that can say, you know what, this is the benchmark, don't go over it. And also there's a couple secondary goals that goes more into the unused doses, outcome of alternative pain medication, obviously, NSAIDs being the big one, obviously, as well as some regional anesthesia now getting into the mix. And then also some disposal methods too. So the study design, we canvassed 18-year-olds who are undergoing C-sections, receiving discharge opioid medications through Duke University. And we did interviews over the phone within 1 month of procedure. And we also referenced the electronic health record just to confirm some of the patient's responses. So interview measures that we're looking at, the amount that was used, alternative pain that they tried to use, disposal method, even concerns over is somebody trying to steal, sell, etc., the unused medication, or even the medication still being used. And then also, as I said before, just rechecking a few things as well as getting patient demographics. So going into it, seems to be a pretty standard group for age-wise. The younger being mostly young, although I was kind of surprised, 45. That's impressive. That was the high end. We do have, I would not say a generalizable group as far as ethnicity goes. We have mostly Caucasian, African Americans, not a lot of Asians. The two or more that we considered was mostly Middle Eastern, Indonesia, etc. So as far as that goes, not extremely generalizable, but we have still a pretty decent group. So the prescribing information. So we interviewed 72 people, but I decided to analyze 62. The reason for this is I noticed that most of those 62 had this exact dosing regimen of oxycodone of 5 milligrams of PO, Q4 hours as needed. You'll see a lot of pain research that will go into oral morphine equivalents, but can you imagine, if you don't deal with opioids every day, can you imagine me coming up to you and saying, okay, I need a script, 500 OMEs, and do it in Vicodin? You kind of sit there and go, you're going to give me like a conversion? I don't really know what's going on here. So I decided to just go with the tangible. Let's stick with a tangible script that we can all work with here. And from what I've noticed also was that most people were either prescribed 15 days or 30 days. There's a couple 10, 20, 40, but for the most part, we stayed with the 15 days of the 15 doses or 30 doses. I apologize. So when asking usage outcomes, people seem to use less than 15 for the most part. That's 82%, 42 of 51 who responded to that specific question. And people with no doses at like 35%. So that really kind of shows you that we need a combination of things because that's not as high of a number for people who didn't need opioids in general. And when breaking that down, I also went into proper disposal, improper disposal, and still possession because that's, once again, unused dose outcomes, okay? And about half of people had what I called easier access. Unfortunately, this is a qualitative study, so there's going to be some ambiguity about who falls into what category, but easier access essentially means not a medicine cabinet. And so easier access to other people, kids, other adults, family members, etc. Now with the alternative pain management, there's at least 30 that said they 30 people that tried to use Tylenol, ibuprofen. There's at least 2 that didn't use anything but heat. And then a few others, somebody actually took their Subutex. That was good. But breaking down Tylenol and ibuprofen, we once again see you need a combination, for sure. And I was actually kind of surprised. There was only 1 report of diversion in general. Grandmother looking for chronic joint disease, pain for chronic joint disease. That was it. I was very surprised about that. So in our patient comments, once again, I emphasizing the fact that patients even say we need a combination. There's a couple that say do not need it at all. There's a couple that say needed, didn't need any more. There was some that said they needed and needed more. And a few others who just didn't know how to properly dispose. Now, I'm not going to say that Duke University does not educate people on how to properly dispose, but I just think that patients just don't read the discharge instructions that we send with them. So going over again, all the results and really looking at disposal. We're trying to curb overprescription, but once again, unused dose outcomes. We need to get them out of the community as best as possible. And for those of you who, for whatever reason, don't know, FDA flush list. You can flush it down the toilet. You can give it to a DEA center. But we need to emphasize that with our patients continuously. Okay. Medication as needed. We didn't really follow patient compliance. They maybe could have missed a dose. They maybe could have not. That's why they had more pain. That's why they needed more, et cetera. As I said, qualitative study. So you're going to get some ambiguities, trying to fit things into categories. And also, as always, we need more data, as always. Future directions, I really want to cut it at 15 doses or less, and to get a study to do that and see, really get the, have a presentation for obstetric groups to see if they'd be willing to do this. Can you do this? Can you do this for a year? What will that look like for your practice? So that's what I really want to get this in the long term. We are also going over urology, neurosurgery, and cardiothoracic surgery that is very similar to studies like this in looking at opioid prescribing. There's my references and questions.